Thrombosis in multiple myeloma is a frequent but very undermined complication. This talk gave me a lot of insight, and hopefully, I will be able to provide some more insight to all these other participants. I'll be covering under these headings: epidemiology, pathogenesis, risk factors, model prophylaxis, and treatment. So let's look into the epidemiology of myeloma thrombosis. This year, uh, quite a few articles related to thrombosis and myeloma have been published. First of them was this British trial, myeloma 9 and 11, with related to thrombosis, a subgroup analysis of over 4,000 patients. I'll be focusing on myeloma 11 trial and not on the myeloma 9. The reason being, myeloma 9 was before any prophylaxis with IMID was advised. So, uh, myeloma 11 is pertaining most in the IMID associated prophylaxis era. So, the trial it evaluated two groups, one containing CRD, that is cyclophosphamide, lenalidomide, and dexamethasone arm, and almost an equal number of participants in the cyclophosphamide, thalidomide, and dexamethasone arm. The candidates who were eligible for transplant were taken up as an abbreviated course, CRD or CTD-A, and taken up for transplant on 3 to 4 cycles. Others were continued on this cycle till maintenance. If they had a partial response or less, then they were assigned to a VCD or CyBody kind of a therapy, depending on the response. So after 2013, one more quadruplet KCRD was added as randomization. Prophylaxis in these patients continued for first 3 months of therapy. Aspirin in low risk and low molecular weight heparin in the high risk treatment arm. Median follow-up was around 16 months. So what they see that if we see on these curves, the cumulative incidence of thrombosis in both the arms is almost equivalent in the CTD as well as CRD arm, both in the transplant eligible and non-eligible patients. However, if we look at the lines, the last line, that arterial thrombosis was also equivalent in the non-transplant arm, but it was slightly higher in the CRD arm who were planned for transplant. Overall outcome with respect to thrombosis in this large subset analysis was similar. There was no effect of thrombosis in the progression-free or survival or overall survival. Next, large retrospective data on the elderly myeloma was also published in the Annals of Hematology this year, around 2,300 patients. CR database 2007 to 2013. 80% of the patient received LEN and 20% received thalidomide. Overall incidence of thromboembolism was at 12 months was around 10%, almost as consistent with the previous study, and arterial thrombosis was around 5%, and it was similar in both the groups. Overall survival was hazard ratio for this was around 0.88. The important thing to realize is that anticoagulation prophylaxis was very less frequently prescribed for many of these patients. So in this study, as per their group, only around less than 20% of the patient received any anticoagulation prophylaxis as per the guideline. Then a large subset analysis among the veteran cancer registry was published, over 4,400 patients, and almost 2,800 after LEN approval in 2006. In these, the thrombosis was seen in around 7.4% of the patients, that is 327 patients out of 4,000 patients within first year of therapy, within a median of around 77 days after therapy. Like we see in the myeloma 11 and in this trial, most of the thrombosis event were occurring in the first few months of therapy itself. A few things more, that deep vein thrombosis in the lower extremity was the more common site. Proximal DVT was the most common occurrence, followed by pulmonary embolism, which was occurring in almost like 1/3 of the patients. And certain risk factors for thrombosis uh, and mortality were associated: high BMI, low ECOG or Charlson comorbidity index, and certain therapy like thalidomide, lenalidomide, or transplant, and higher number of therapies in the first regime were more associated with mortality and thrombosis. Another real-world data published in Hematological Oncology Journal. This was a retrospective multicenter data of around 322 patients, and thromboprophylaxis was again inadequate in over 20% of the patient. This compared VCD and VTD. Just have a look at the last line. The thrombosis is almost 4 times more in the VTD arm as compared to the CyBody arm, which was clinically significant, despite DVT prophylaxis being given in the VTD arm. So what we have, that myeloma, we have IMIDs as a very important, powerful agents, but they are they behave like an Achilles heel with respect to thrombosis. When given alone, the incidence of thrombosis is not very high, especially in newly diagnosed patient. But the moment you add another drug, be it dexamethasone, melphalan, doxorubicin, or any other drug, the incidence of thrombosis rises up to 10 to 25% or even higher. The incidence is far lower in the relapse or refractory patient, where the incidence is less than 10% across the studies. What about the data? Daratumumab, a meta-analysis was published this year, meta-analysis of around 6 studies. What we see that overall, with the DERA-containing regime, the risk of thrombosis was lower. It varied from around 0 to less than 5% as compared to non-DERA RAMs in the comparator, that is varying from 0 to around 9.6%. Sorry, 0.9 to around 6%. As expected, the risk of thrombosis was higher in newly diagnosed patients and in those patients who were given amide-containing regimens. What about CAR-T? Again, one more study published with respect to thrombosis in post-CAR-T patients. 54 patients, 4 developed thrombosis, that the incidence is around 7%. So most of these were venous thrombosis and no arterial thrombosis were observed. All were symptomatic venous thromboembolism, and median time from diagnosis of CAR-T to VT diagnosis was around 17 days, very low. So most of these patients would have been admitted at that time. Treatment of choice was DOACs in these patients, and duration was it's from 90 days to infinite. The important thing was no major bleeding or recurrent thrombosis was seen with this treatment. So what we see is that around 8 to 10% of the patient were developing thrombosis across the regimes or across various treatment which we use nowadays. Let's look into the risk factors. So the risk factors can be patient related or disease related or therapy related. If we look at the patient related risk factors, higher age, especially more than 75, is a strong risk factor. One of the most important risk factors is the previous history of venous thromboembolism in the patient. Then comorbidities like CCF, liver disease, and other things, and erythropoietin use or darbepoetin use has also been associated with increased risk of thrombosis. If we see the disease-related factors, newly diagnosed myeloma has far more higher risk than a relapsed refractory myeloma. Then abnormalities in chromosome 11 can have higher risk. Then numerous thrombogenic agents have been studied, like microparticle associated tissue factor, TAFI, plasminogen activator inhibitor 1, acquired protein C resistance, P-selectin, endogenous thrombin protein. All these have been associated in their respective studies with higher risk of thrombosis. So essentially, what we have that IMIDs, they act as the bad boys with respect to thrombosis. However, the exact mechanism of thrombosis in these is not exactly defined. What we have is the various hypotheses. There is a role for increased VWF or factor VIII and even tissue factor. There is enhanced platelet activation and aggregation seen. And activated protein C resistance, which can be mediated by cytokines. The moment you add DEXA, there is a increase P-selectin, VWF, and factor VIII levels. And if you add a doxorubicin containing regime, doxorubicin is known to induce procoagulant phenotype in endothelial cells and increase the plasma thrombin as well. Lenalidomide per se alone, it upregulate cathepsin G, increase endothelial stress markers like ICAM and VEGF, and high levels of P-selectin receptor has also been seen with lenalidomide-based therapy. So we have the risk factors. Now, what we next need is other risk assessment models. And when we think of risk assessment in malignancy, what first comes to our mind is a coronary risk score. But just remember, this risk score is mainly based for solid cancer. And up till recently, we didn't have much specific related to myeloma associated thrombosis. We see myeloma is not counted as a high risk in this, but frequently patients will have a low hemoglobin, higher BMI, or a low platelet count. So eventually, and the studies incidence is around 4 to 10%. So even as per the coronary risk score, myeloma falls into a intermediate or a high risk of symptomatic VT kind of a thing. However, this is not myeloma is coronary risk score is not able to predict thrombosis in myeloma and is not frequently used. To our rescue came these two scores. One of the first one is Impede VT. Both of these scores were published last year. Impede VT was published from the SEER data of around 4,000 patients last year, and it consists of the various points. Important being immunomodulatory drug, that is IMIDS, high BMI, pathological fracture, EPO use, use of dexamethasone, high or low dose, use of doxorubicin, and previous history of VTE. The negative points are given to ethnicity, Asian ethnicity, lucky we are, and prophylactic or therapeutic use of any anticoagulant prophylaxis. So you can have low risk to high risk. Low risk, the risk of thrombosis is around 3.3%, which increases to up to 15% in high risk patients. And the next is the saved score, which is used specifically for IMIDS. This was also published last year. It gives points to surgery within the last 90 days, Asian race, negative points, previous history of VTE, age more than 80 years, and dexamethasone use, low dose or high dose. And both low and high risk have been defined as hazard ratio 1.85 and 1.98. What are the guidelines with respect to prophylaxis? These guidelines were given as early as 2014 by IMWG and then endorsed by AMN. Similar guidelines were endorsed by AMN in 2015. What we have is like patient-related risk factor, disease-related, and treatment-related risk factors. So various patient-related risk factors are given 1 point: high BMI, age more than 75, history of VTE, thrombosis, coagulation disorder, or comorbidities. All are given 1 point. Then 1 point is given to disease-related risk factor like diagnosis of newly diagnosed myeloma or evidence of hyperviscosity. Importantly, just look at the treatment-related factors. IMID in combination with low-dose dexamethasone, 1 point. IMID in association with high-dose dexamethasone or doxorubicin, 2 points. IMIDs alone, 1 point. Erythropoietin use, 1 point. What they gave was a risk stratification and recommended prophylaxis. So if you have 0 point, that is a relapsed refractory patient without any IMID-based therapy, so the risk is low. No prophylaxis is required for them. But and if you have an intermediate risk, that is 1 point only, any newly diagnosed patient of myeloma, you give aspirin. But the moment you add IMIDs to these newly diagnosed patient, you add dexamethasone, this aspirin prophylaxis is insufficient as per IMWG. You need to give a low molecular weight heparin at prophylactic dose or therapeutic doses of warfarin to these patients. So what does the future holds? So adding biomarkers to the risk assessment like thrombin generation, P-selectin, etc., it can be added and give us a more refined score. Something in this regard is going on with the roadmap multiple myeloma cancer-associated thrombosis scoring, and which is being incorporated. In the real world, we need patients. We meet patients with thrombocytopenia. We meet patients with renal failure. We need trials in them so that accurate thrombosis risk can be determined. And definitely DOACs, DOACs, DOACs. You can't give low molecular weight heparin to your patients for 3 months, especially if they are thrombocytopenic. You, warfarin comes with its own risk of polypharmacy and drug interaction. So DOACs are going to be the future in these things. And indeed, we had a study published in 2020 in BJH. 50 patients, phase 4 study, 2.5 milligram a lower dose of APIXABAN being given for 6 months in Len-based and pomalidomide-based therapies. Both combination of patients were seen relapse and newly diagnosed. What we see is that no major bleed or only 3 clinically relevant non-major bleeds. So it's clinically safe and no incidence of thrombosis, DVT, PE, MI, or death was seen in these patients. So a relatively safe drug, at least in by this study.
Mukul, we have got
Authors,
1 minute only.
yes, sir.
Yeah.
So the authors have proposed a score using DOACs, in which they say that for patient with no based on impede score and risk assessment. So if patient has no risk, no thromboprophylaxis to begin, and with very high risk, DOAC therapeutic doses is to begin. For low risk and high risk, aspirin and DOAC with a limited duration can be given. What happens when the bird is out of the cage? That is, the thrombosis already occur. Patient can present with the usual signs of thrombosis, redness, pain, or and if the PE is occurring with breathlessness or tachycardia. Diagnosis is by compression ultrasound or CTPA. Treatment, just discontinue IMID for the duration of anticoagulation you are giving and resume IMID only when full anticoagulation is established. If thrombocytopenia risk is low, add oral anticoagulation, otherwise continue with LMWH only. Heparins for 5 days till INR reach, therapeutic INR reach, and extended therapy with LMWH or VKs is considered at least for the duration of the IMID therapy. What about other PCTs? There was risk of thrombosis, which can be seen with MGUS also, almost to the tune of 6.1%. Risk factors being age more than 65 years, M protein being more than 1.6 gram per deciliter, or disease progression. Most of these events are again occurring in the first 6 months, and risk is higher with history of VTE or immobilized patient. Other studies have documented this risk as around 3%. Issues that why were these patients tested for MGUS? Probably they had some symptoms or some underlying other disorder for which they were tested. What was the contribution of that disorder is still unknown. So MGUS is still a raw area with respect to thrombosis incidence. But thrombosis in poems is a definitely high risk area. 83 patients, almost one third of these developed thrombosis, 16 arterial and 11 venous events. Previous VT in almost 12% of the patient, and active disease was present in almost 23 patients. So what these authors suggested that patients with POEM, if they have active disease at diagnosis, they need two agents for therapy: prophylactic LNWH and a antiplatelet drug, at least till their serum VEGF level is less than 1,000. When they go into remission and are on maintenance, prophylactic LMWH is to be continued. And when in remission, then nothing is required. To conclude, I'd like to say that thrombosis in myeloma is a real concern. It's more in newly-diagnosed than relapsed refractory myeloma and more commonly seen with IMID-containing regimes. Prophylaxis, the guidelines have been available since almost 6-7 years, but they are not uniformly practiced. High incidence of thrombosis can be seen despite prophylaxis. Better risk assessment tools are needed, and DOACs can be game changer in this regard.